There have been a number of refinements to second-generation drug-eluting stents, and we're here to talk about the new study that gives us a better idea of how these widely used second-gen devices compare to earlier drug-eluting stents, but based on the complexity of the underlying CAD. And it is a patient-level pooled analysis of 6,081 patients. And I am with the author, who is Dr. Thomas Pilgrim, an associate professor at Bern University Hospital and University of Bern in Switzerland. Welcome back finally again. It's so nice to see you.
Welcome.
Now this is for JAK interventions. So the very first thing I wanted to ask you is, why did you conduct this particular study? Because you're looking at second generation and first, and haven't we done that already?
Exactly. I think there's several studies that have compared second generation to early generation drug-eluting stents in randomized controlled trials. So actually there's no need to do this pooled analysis of individual patient data. However, what has not been done so far is to assess safety and effectiveness of newer generation drug-eluting stents as compared to early generation drug-eluting stents according to lesion complexity as assessed by syntax score, and this is what we are interested in. So what is the effect of lesion complexity for those stents?
Now this is JAK interventions for November 2015. You evaluated data from 4 randomized clinical trials, correct?
Exactly. So CERTAX trial, LEADERS trial, RESOLUTE trial, and Bioscience trial.
So you have a number of people to look at here. How big was the study?
Exactly. So we included approximately 6,000 patients treated with either newer or early generation drug-eluting stents. We have to say that 3/4 of all patients have been treated with newer generation drug-eluting stents, whereas about 1/4 of patients has been treated with early generation drug-eluting stents.
So you have all of this data. How did you conduct the study?
Okay, so all of those patients have been pooled into one database. And then we actually stratified patients according to lesion complexity, anatomic lesion complexity as assessed by the syntax score. So the median syntax score was approximately 11. So we had like patients with low lesion complexity, defined as a syntax score below 11, and high lesion complexity, defined as a syntax score above 11. So then we had the primary endpoint, which was a composite of cardiac death, myocardial infarction, and clinically indicated target lesion revascularization. And then we had additional endpoints, which was one safety endpoint, definite stent thrombosis, and one effectiveness endpoint, which was target lesion revascularization. And what we have seen that newer generation drug-eluting stents actually reduced the risk to experience this primary composite endpoint as compared to early generation drug-eluting stents. However, there was no interaction between high lesion complexity or low lesion complexity. However, what we have seen is with regards to effectiveness endpoint, target lesion revascularization, and definite stent thrombosis, there was a significant effect of lesion complexity. So patients with a higher lesion complexity tended to have an even greater benefits from newer generation drug-eluting stents as compared to early generation drug-eluting stents with significant p-values for interaction.
So these refinements are definitely benefiting what we would consider the higher risk of the more complex patients.
Exactly, the more complex patients, exactly.
That's pretty impressive. So how do we close the gap between PCI and surgical revascularization? Because that's what we're all trying to get to eventually.
There have been randomized controlled trials comparing percutaneous coronary intervention versus CABG. And however, we cannot extrapolate the findings we have from this study to those trials comparing PCI versus CABG. So we know that in patients with increasing lesion complexity, for example, with a syntax score above 23, surgical revascularization is superior to coronary artery intervention percutaneously. So, of course, now that we've seen that even in more complex lesions, we tend to have an even greater effect with newer generation drug-eluting stents, we see that this gap may close. However, it is not closed yet, and we are far from having a closed gap right now.
But it certainly does seem like the gap has closed a little with the second generation stents. And that's important if you're going to make an analysis between PCI and surgery. The bottom line, the effectiveness and safety of these new generation or early generation stents, they may be more pronounced than people with moderate to high anatomic complexity. Is that
exactly, right? Exactly, yeah. They tend to have an even greater benefit.
And so when you want to tell somebody the bottom line message that you have, what is it based on this analysis?
Well, I think it's clear if you want to treat patients with percutaneous coronary intervention, nowadays you should use newer generation drug-eluting stents, but this effect or this benefit that we have from newer generation drug-eluting stents is even greater now with higher lesion complexity. So if you want to treat patients with a high anatomic complexity, you definitely have to use newer generation drug-eluting stents.
And this is a very optimistic paper, and it's in JACC Interventions in the November 2015 issue, so please look for Dr. Pilgrim's paper there. At TCT, I am Rick McGuire, the Executive Editor of Cardiol World News.